I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm Dr. Jordan Robertson. I'm a naturopathic doctor, and my focus in my clinical practice has been on women's hormonal health, which means I spend a lot of time talking with women about their menstrual cycle and what is normal in their menstrual cycle and what needs better assessment with respect to their menstrual cycle. And today I want to focus on a topic that I don't think we spend enough time on. I think we've normalized the amount of blood flow that women have or should experience during their menstrual cycle. And this leads to a general underassessment of women related to their heavy menstrual bleeding, and women passing off this symptom as something that they just have to deal with or put up with or live with. So my goals for the conversation today is to help you understand what the difference is between a regular menstrual flow and a menstrual flow that needs further assessment, and also to give you some ideas around some of the causes of heavy menstrual bleeding so that when you're presented with solutions by your practitioner, you can see maybe what a reasonable solution might be, or what if the solution is temporary and maybe you need to look for some further, more root cause type solutions. So heavy menstrual bleeding is defined as menstrual blood loss of more than 80 milliliters through the menstrual cycle. And this is challenging because, obviously before the invention of the Diva Cup, women really had no idea how much menstrual blood loss they had. And we've got, there are some picture, surveys that women can take that, they circle the number of tampons and the number of pads that they soil through a 24-hour period. That can help give us an understanding of how much blood loss women are having. But like historically and in the research, when we're relying on a woman's ability to recall her experience, we underestimate how impactful her experience is, because we either assume that she doesn't know how much blood loss she has, or we assume that she's exaggerating about how much blood loss she has. Like in the research, anytime we've had to evaluate things in women's health where the woman's recall of her experience is how we set the stage for treatment, it doesn't go that well. We don't do that good of a job. It's different than if we could measure it in your blood and be like, oh yeah, you totally have heavy menstrual bleeding. But instead we rely on a woman's recall and experience. And even in the literature, it will say, well, women don't really have any idea about their menstrual blood loss. And you can imagine that this actually sets sort of the wrong stage for the way that we treat this medically. So if in the research we say, well, women don't really know how much blood loss they have, and and then their practitioner physician is reading that literature, and that literature is making recommendations based off, and treatment suggestions based off whether or not women do or don't have quote unquote heavy menstrual bleeding, creates a big disconnect, because now your practitioner is the gateway to solutions, and their willingness to offer solutions and assessment, which we'll talk about in a second, depends on how good your story is about whether or not you have heavy menstrual bleeding. And so I have definitely over my years worked with women where they have felt like their experience of menstrual bleeding was downplayed or normalized by their practitioner. And yet it's causing complete dysfunction in their life for the amount of blood loss that they have. So there is a big disconnect there. We rely on your recount of your experience we normalize a lot of things in women's health, right? Like it's passed down from generation to generation. Women believe that they have heavy menstrual bleeding because their grandmother's grandmother's grandmother also had heavy menstrual bleeding. And that's not a good enough reason for you to suffer with your symptoms, whether we think there's a genetic basis, and there is a bit of a genetic basis for maybe some of the causes of heavy menstrual bleeding. But we normalize the woman's health experience in general, where women think that, it's normal for them to experience that, or this is something that plagues the women in their family, and therefore they are destined to struggle with this symptom. But now your recount of your experience has to be told to a practitioner, and that practitioner holds the keys to assessment and holds the keys to treatment. And the research downright says women don't know whether or not they bleed a lot or not. And I feel like I have a big problem with that. I don't know. And I'm sure as you're listening, you're like, well, it can't be that bad, Jordan. It can't be. But maybe you are listening and thinking, yeah, this has been my experience, actually, that I tried to tell my doctor I had heavy menstrual bleeding, and they said something like, well, that's what happens after pregnancy, or welcome to your 40s, right? Or something like that. And so I want to spend the majority of our time today talking about what some of the underlying causes of heavy menstrual bleeding are, and how you can advocate for yourself to get better assessed, because assessment is the key to finding a solution to your problem, right? And if we don't offer women that assessment perspective, then we're really we're not doing a good job of supporting women. And given that, there's a high prevalence of iron deficiency in women, right, where heavy menstrual bleeding is certainly going to be a potential cause for that. And we have a lot of lost work and productivity and just quality of life in women who suffer from heavy menstrual bleeding. This is an absolutely necessary conversation for us to have. So first, let's talk a little bit about regular menstrual blood flow, because I don't think many women understand or know what is the normal experience for blood flow. And then we can talk about how heavy menstrual bleeding kind of deviates from that. But your production of endometrial lining, and that's what's shed with your menstrual period, is the endometrial lining. The production of endometrial lining is a process that happens over sort of the 3-ish, 4-ish weeks leading up to your menstrual flow. So it's the endometrial lining thickens through your menstrual cycle. And when I say menstrual cycle, I mean the full month, not just the 4 days that you're bleeding. Your menstrual cycle is actually the 28-day experience. That endometrial lining is thickened, mostly under the influence of estrogen, through your menstrual cycle. And it matures after ovulation in preparation of catching an egg and implanting an egg and then growing a successful pregnancy. So the first half, if we wanted to speak about it in real general terms, the first half of your cycle is that growth of the endometrium. And then in the second half of the cycle, under the influence of progesterone, which is the hormone that's released at ovulation, the endometrial lining, I'm going to use the word matures. So it changes, and it matures in preparation for the egg. Now, if you don't fall pregnant in any given cycle, which there are, hundreds and hundreds and hundreds of cycles through your life, but you don't fall pregnant in, as progesterone levels start to decline at the end of the 2 weeks of that luteal phase, it signals that it's time for that endometrial lining to be shed. And as those hormone levels fall, you start to initiate that next cycle. And so it's the declining levels of progesterone that initiate the onset of menstrual blood flow. And as that progesterone is withdrawn, it changes what's going on biochemically in the endometrium, and that triggers the loss of menstrual tissue. And so estrogen levels and progesterone levels are relatively low during that menstrual phase of your cycle, which is going to be day 1 to day 4, 5, 6, depending on how long you bleed for. And as that endometrium is being shed, right, if it's undergone those stages of development, what is bled is a nice period, right? And I always call it a nice period, and my patients are always like they feel like there's no such thing as a nice period. But in theory, if you've gone through those developmental stages of the endometrium, The period that is bled is nice. It's not full of clots or excessive amounts of tissue. It is a manageable amount of blood flow. It is painless, and it stops after 4 or 5 days of bleeding. So you can, as you're reflecting on your own experience, you may start to think about different scenarios where blood flow has not been that nice, where maybe you spot many, many, many days before your period actually initiates. And that may be caused by lower levels of progesterone or that early decline of progesterone before you actually make it to the end of your luteal phase. And so that declining progesterone level can cause some almost leaking of the blood vessels and endometrium before your true day one. You may have an excessive amount of blood and tissue lost when your period initiates. And that's kind of what we're focusing on today. And you may experience pain, right? Which we've addressed in other episodes. The endometriosis episode, we addressed menstrual pain. And then you may experience a longer window of menstrual bleeding than this sort of nice 4 to 5 days, right? And so if you find yourself reflecting on your own experience and you're like, there's nothing nice about my period, then we're going to want to sort of investigate the causes of heavy menstrual bleeding and start to think about what some of your solutions might actually look like. So the reason that I'm such an advocate of testing for endometrial bleeding or for heavy menstrual bleeding is that the cause is not easy to discern without us doing some deeper investigation. Now, when you sort of walk through your doctor's door, you need to have the answers for a couple of questions for us to be able to help you figure out what the cause of that heavy bleeding actually is. And it helps guide us towards what kind of assessment women deserve in order to, be better understood for what's going on with them. So as I walked you through that sort of normal menstrual cycle, you can see that there's maybe opportunity for a not so normal or an atypical experience that's going to get in the way of whether or not that endometrial lining is nice and is when it's shed is this nice period. So starting from the very beginning of when we first get our period as young women can experience heavy menstrual bleeding as their cycles begin. And part of that is because progesterone is responsible for that maturation process of the endometrial lining. And it's only released in cycles when an egg is also released. And so young women, as their cycle is getting established and maturing, and their brain is getting connected with their ovaries, because that does take some time, they may experience heavy menstrual bleeding. Young female athletes commonly experience heavy menstrual bleeding because often their cycles can be anovulatory because of the impact of their exercise and training on their menstrual cycle. It's common for young female athletes to have heavy menstrual bleeding because they may not have an ovulatory cycle. This also shows up in women in perimenopause because as we start to float towards our final years of menstruation, not every cycle is ovulatory. And so you can see that, depending on where you are in your life, the other things that are going on in your life, this is going to influence how we feel about your heavy menstrual bleeding and maybe point us towards a cause and then also point us towards some solutions. So our young 15-year-old gymnast who has heavy menstrual bleeding needs a different solution than our 47-year-old perimenopausal woman with heavy menstrual bleeding, even though the cause is is the same because they're not maturing that uterine lining with anovulatory cycles. And so what I want you to sort of be mindful of, or the things that we need you to think about, is to track your cycle, right? So obvious cycle length changes, whether or not you're ovulating, which tracking that ovulation can be really helpful to communicate with your practitioner. And so when we move through those 3 to 4 weeks as we prepare that endometrial lining for shedding, if any of those steps are disrupted, then the uterine lining that is then shed towards the end of that cycle may be excessive, right? It may be more blood flow than is ideal. And that's why we experience sort of that sort of hemorrhaging and maybe a lot of loss of tissue because the endometrial lining that's being shed is coming out too rapidly and it maybe hasn't gone through that maturation process. So, the other causes of heavy menstrual bleeding that we need to think about kind of fall into two categories. We either consider them to be what we call a structural cause. And so there are growths or changes that may influence heavy menstrual bleeding. Or the cause might be non-structural, which is when we're looking for, things like clotting disorders, things like those anovulatory cycles I was speaking about. So a non-structural cause is there's not like a physical thing that's in the uterus that's making you bleed more, but more that there's an underlying condition that's influencing the amount of blood that's lost. And so we will go through those as well, because like I said, we can't just look at our 45-year-old woman from the outside and guess why she has heavy menstrual bleeding and then apply a treatment. And so I want to cover kind of all of those possible causes of that heavy bleeding so that you feel more equipped when you go into your doctor's appointment. Before we get into those causes, can I just say that if you are suffering or struggling with heavy menstrual bleeding, that you absolutely deserve to be treated and assessed. I can't tell you the number of women that I've worked with that explain their menstrual bleeding to me and describe themselves needing to change their entire outfit in the middle of the night or sleeping on towels. I've had patients that sleep sitting upright during their period because the blood loss is so significant that they basically have to create like an entire, system around their body full of old towels and pads and whatnot to try and catch all of the bleeding, and have been told by their practitioner that this is just something that happens when they get older. And I just can't accept that, right? I can't accept that women have that significant amount of blood loss and they are not investigated. And so first off, if you're listening and you're like, I have this, right? Like it is interfering with my life. So even if you're not sleeping on towels, but when you leave the house during your period, you have fear that you're going to have a massive like gushing episode. If you're needing to change your protection so frequently that it's interfering with your day, like this deserves to be assessed and this deserves to be treated. You deserve to be treated. And there are a few treatment options for heavy menstrual bleeding, and whichever one you choose is fine, right? Like whichever one you choose needs to fit with the quality of your life and what you are here to do here on earth. I mean, and no judgment on what you choose. So sometimes, and when we talk about some of those options, when women sit down in my office, they think that I want them to do the most natural treatment possible. To me, unsupported or untreated heavy menstrual bleeding is such a risk of you developing iron deficiency, of you interfering with your quality of life, you not exercising, right? Like all the other things that I want you to do. If an IUD solves that, like I think this is a brilliant solution for women who are literally afraid to leave their house because of their heavy bleeding. So whatever you decide to do treatment-wise, it just needs to support you in your life and help you get back to feeling more confident about your cycle and about yourself. So I'm going to preface with that. You deserve to be tested, and whatever you decide to do for treatment is cool with me. I think it's it's a great thing if you can get some level of support. But the assessment piece has to be there. So if you are offered treatment and we don't know why you have heavy bleeding, to me, that's where there's a gap, right? Because sometimes getting an IUD doesn't fix the problem if we haven't actually figured out what the problem is. Or sometimes taking the pill actually creates more challenges than it solves if we don't know what the actual reason for your heavy bleeding is. So please get assessed. And then whatever you decide to do, high five, girl, like do your thing. So let's talk about structural causes first. And this is much more common, or it is maybe the we don't see structural causes in adolescence. So if you're listening as a young woman or if you're listening as a mom, we don't see fibroids or structural causes of heavy menstrual bleeding. It's very, very rare to see that in a young woman, okay? They are much more likely to have heavy bleeding because of an anovulatory cycle, and that would either be from this brain to ovary connection not being well established. We definitely see heavy bleeding in women who have, a disproportionate amount of exercise versus the food that they take in, meaning that they don't have, they have a relative energy deficit. This is where our female athletes have heavy periods. Or if women are, having polycystic ovarian syndrome, they often also have anovulatory cycles, and then they may have heavy menstrual bleeding. It just may be more irregular, but when they do bleed, it's significant. But structural causes are common in women over the age of about 35 is where we start to see an increase in polyps in the uterus. We see an increase in fibroids, which is like a physical mass that's grown in the uterus, benign, but it's still a physical structural change in the uterus. Or we may see adenomyosis, which is an increase in growths in the endometrium. And all of these have to be assessed based on ultrasound. And so you can see from that perspective, why assessment is so important and why, slapping treatment on a woman who maybe has really significant fibroids, slapping treatment like the pill, for example, on a woman who has fibroids may not actually help us in the long game of that woman's health, because if we never understand the cause or what's in there, or what's going on, we may not be offering her the best solution, which for some women, the best solution looks like surgery, or the best solution looks like a partial hysterectomy. And so that's why that assessment piece is so important. It also can help diagnose any coexisting issues like adenomyosis or endometriosis that may be causing other symptoms associated with the menstrual period. So a heavy period on its own isn't necessarily painful, but if you have other symptoms that go along with your period, like it's heavy and it's painful, then again, that assessment piece is really important so that we can get you the right support and the right treatment. But those structural causes really need to be assessed on ultrasound, and that should be one of the first things that you're offered when you have heavy menstrual bleeding. Now, when to assess you through your cycle, generally the gold standard is to go for your ultrasound right after a bleeding episode so that we can see the endometrial lining at its thinnest, right? Like when you've shed all there is to shed. That's the best time for us to go in and look. I will say that most often women are given a requisition for an ultrasound and they just book an appointment whenever. And that means that the ultrasound maybe isn't totally conclusive around what their causes are of their bleeding. Because if we catch them right before their period and we see it thickened endometrial lining, it's like, well, yeah, that's supposed to be there at that time of your cycle. So if you can, you want to try and schedule your ultrasound in the first half of your cycle, preferably in those first few days after your period is expected to be over. Now, the non-structural causes is more diverse and requires a lot more questioning and a lot more maybe lab work than maybe women are being offered currently to assess their heavy bleeding. Like if you think about the processes that are required to grow endometrial lining, right, to ovulate, to then clot when you're shedding that uterine lining, you can start to see that a woman's entire health can start to impact the amount of blood flow she loses with her period. So it's important that we do a thorough examination for women and looking for things like, other symptoms that you might experience. So I mentioned briefly hypothyroidism, which women can associate as being a cause of fatigue, maybe a cause of challenges with metabolism and weight gain, challenges with temperature regulation, like feeling cold all the time. Your thyroid is implicated in bleeding time and clotting. And so both hyper and hypothyroidism will influence menstrual bleeding. but hypothyroidism certainly being the more common of the two, again, more often diagnosed in women and often diagnosed in that perimenopausal stage of life. So a good thyroid panel needs to be done in order to assess whether or not your hypothyroidism is contributing to your blood loss. And if you have hypothyroidism and you have heavy menstrual bleeding, then there's a worthy conversation there to make sure that your medication use or needs haven't changed, and that your heavy bleeding isn't a consequence of just not that well controlled hypothyroidism. We also want to test to make sure and see what's happening from an ovulation perspective. So, like I said, you have to ovulate in order for us to have that good maturation of the endometrial lining. And we can test women to understand their cycle better, to check and see if they are ovulating. That's a relatively simple blood test to say yes, no, like ovulating or not. But then the other hormones that are implicated or related to ovulation, like prolactin, right? Which when prolactin, which is our milk producing hormone, is elevated, it can influence our ability to ovulate and influence menstrual bleeding. We should test women for other hormones that come from our brain, like those pituitary hormones, especially if she's had a concussion and hasn't had, regular menstrual cycles since her concussion, or maybe have other, hormone related symptoms that we should be assessing to figure out, like, why is she not ovulating? So certainly if you're 48 and sometimes you're not ovulating, like, we know, or we should still investigate you. I'm not going to take that away from you, but we know it's because we're moving towards that menopausal stage of life. But if you're in your mid 30s and you're having really heavy menstrual bleeding, we can't chalk that up to age. That's not a thing. And you're too far away from menopause for us to say, don't worry, one day you won't have to deal with this. You deserve to be treated sooner and assessed sooner. So the other things we should be looking for is signs of anemia. So it's a catch-22. I joke that I would like a do-over for building a woman, because there are some systems in our body that I feel like are just built backwards, or there's a slight oversight in our physiology. But iron is actually a relatively important nutrient for clotting. And yet, the more you bleed, right, the more you bleed out, the lower your iron is going to be, and then the more difficulty we have in clotting. And so again, this idea that when we delay assessment and delay care, we actually create problems with heavy menstrual bleeding, right? We create more bleeding when we don't assess quickly, because we're, in theory, putting that woman at risk for iron deficiency. And when I'm talking about iron deficiency, I'm not just talking about your hemoglobin. So if you've had your blood work done and your hemoglobin is normal, you need to have a further assessment of looking at your iron storage. So your ferritin needs to be adequate. I would argue if you have heavy menstrual bleeding, it needs to be over 40 for us to not consider that to be part of the problem. And I've met lots of women with heavy bleeding and they say, well, I'm not anemic yet. And their ferritin is like 4. And so we need to do a slightly better job of looking at this. But if you have symptoms of iron deficiency, like fatigue, sleeplessness, meaning like restlessness in your bed, shortness of breath, fatigue, shortness of breath when you like run up the stairs or do like a relatively small burst of physical activity, then we certainly will want to look at your iron as well. So because you can see that there are these like non-structural causes, and I would throw in there women who have fatty liver disease or have liver inflammation are at risk of heavy menstrual bleeding, because our liver is responsible for creating some of the platelet factors that are necessary for clotting. We see women who, maybe have an inherited clotting disorder, but have normalized their heavy menstrual bleeding their entire life, and yet have a bleeding disorder that's influencing their heavy bleeding. We might even see some medications like antidepressants may increase heavy menstrual bleeding for some women. So it's a really it needs this long assessment and history taking and question asking in order for us to figure out what's going on with women so that we can give her the best possible treatment solution. Now, when we look at solutions, like I said, it honestly doesn't matter to me what you choose to do. I think what we have to hold in our hand as being the highest goal is for you to get back to normal. And maybe your treatment solutions look like a layered approach where, you're offered a kind of a 911 type approach. There are some particular medications, tranexamic acid, for example, which just literally slow the bleeding in this particular cycle. And sometimes that's necessary for us to get a grip, get a focus on what's going on while we investigate you. Like I said, your ultrasound should really be timed with your cycle. So if you're going to have to suffer through cycles while we wait for assessment, then there's nothing wrong with using medication on a 911 basis, meaning that you're using it just to patch repair, go to work, not sleep on towels, and while we get our feet under us as far as an assessment goes. But really, when we look at what's happening in the uterine lining, the what we call the pathophysiology of what's happening, quite a lot of the root or the basic cause of heavy menstrual bleeding, and this is assuming there's no structural cause, is inflammation. So there's actually quite an inflammatory response that happens right before we have our period. As progesterone levels decline, progesterone basically prevents inflammation in the uterus. And this inflammation I'm talking about, when it's normal, it's fine. There is inflammation that happens in our body that is normal and fine. And as progesterone levels decline, it initiates that bleeding, and it initiates an inflammatory process that is needed and necessary in order to initiate heavy menstrual bleeding. But when progesterone levels are low, when they withdraw too early, when women have underlying inflammatory conditions, now we've created a bit of a scene where the inflammation that's in the uterus that's associated with blood loss or initiating bleeding is actually going to influence the amount of blood that's lost. It influences the ability to clot. It influences the amount of tissue that's released. And so interestingly, when we look at some of the solutions for heavy menstrual bleeding, again, non-physical causes, they're often in the anti-inflammatory realm of support. So there's great research on Advil and ibuprofen. There's great research on ginger. There's great research on, or mediocre, I'll say, research on boswellia, which is another anti-inflammatory. So we actually look down that pathway, can we change the inflammation that's happening in the uterus for women that then influences the amount of blood that's lost? I would say that that's a reasonable conversation for you to have with your practitioner around slowing inflammation and slowing blood loss, like I said, as you investigate what that underlying cause is for heavy bleeding, because that's really where the root of the solution needs to come from, is not just looking at how do we mop up this particular period, but can we get to the underlying cause so that you can then support that and treat that? Because not ovulating or having hypothyroidism or having iron deficiency or having adenomyosis, they're all going to cause you more problems than just bleeding, right? Bleeding is the tip of the iceberg. And so the assessment part needs to really be there. So I hope what you come away from this episode with is just some empowerment around, you do not have to live like this. You don't need to, well, right now you might need to put towels down when you go to bed, but that's not a solution, right? And waiting for menopause is also not a solution, because whether you have 3 cycles to go until menopause or 15 years to go until menopause, waiting for menopause is not a solution. It's not a solution. And so I want you to get assessed now, and I want you to take it seriously and advocate for yourself in your doctor's office, because maybe you do need surgery. And if that's going to be the final answer, why are we going to wait and muck around for a year when the answer could be so concrete and so final for you? So I want you to come away from this episode feeling empowered to get assessed, to investigate what the issue actually is, because it's probably influencing your health more than just the annoyance of going through a lot of menstrual products or having to sleep on towels. I want you to take it seriously because it is a reflection of other things that are going on in your health. It's not the only thing that's going on. And I also want you to know that there are classes of solutions that range from, ibuprofen up to surgery that you should be offered as a buffet of treatment options. I'm borrowing that term from Matthew Leonardi, who we interviewed a couple of weeks ago on endometriosis. There is a buffet of solutions. And if you, we joked, if you don't like the crab legs and don't have the crab legs, you should be offered a bunch of solutions for this problem, and choose one that gives you back your life, right? Like choose the one that allows you to function, that allows you to exercise, that allows you to sleep, right? This is getting in the way of major areas of your health and becoming an obstacle to you being your best self and living your best life. And so I want you to take it as seriously as I do. This one's really important. So I hope you enjoyed the episode. Go get tested, go have an ultrasound, and let's get this heavy menstrual bleeding fixed. I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.